Good morning, ladies and gentlemen. It's a great pleasure to be with you, and thank you for Mervet, Faraidi, and Oid for the invitation. Just before I start, I have a confession to make. I never done any renal denervation, so I'm supposed to talk to you about a procedure that failed that I've never done in my life. So that's very challenging and interesting. But on the other hand, I've seen Dr. Al-Habib, who's in the audience, doing a couple in our cath lab. So probably I have some idea about how it's done, so just stay tuned. Okay, here is the outline. When something fails, you start to ask questions. That's the basic thing to problem solving and troubleshooting. So the first question, is the hypothesis that denervation treat hypertension patients and normalizes the blood pressure really sound and solid and plausible? So that's the first question. Are we really testing the right hypothesis? Then you look at the evidence or the translation of this hypothesis to a clinically applicable studies. And so we're going to go over the simplicity 1, 2, and 3 and look at the rigor of the studies. Then you ask you ask yourself, is the technique and the technology really robust and good in terms of addressing this issue and treating this matter? And finally, you look at the population that we're treating, or the population at risk. Are we treating the right population? Because sometimes you do have everything in place, but you're treating the wrong patient, then you can have the wrong result. There is obvious reasons in my mind why this failed, but I'm not gonna talk about that. I'm in the intervention group meeting, so I'll talk about the less obvious reason why this procedure failed. So this is by way of background. Hypertension is a very common disease. There's about 10% prevalence of resistant hypertension, which is defined as if a patient is taking 3 anti-hypertension medication and he's not yet in target, we call them persistent or resistant hypertension. This led to the exploration of novel techniques and ways to treat those population at risk. And when we look at the hypothesis, is this hypothesis solid and sound? We have to evaluate it against a setup of criteria, which called Hill's criteria. Hill's is a SIR that published in 1969 sets of criteria to assess the plausibility or the causality of any hypothesis. Afterward, Rutherford added some other criteria. So at the end of the day, we have a Rutherford-Hill's criteria. And against this sets of criteria, we assess, is this really plausible? Is this really a causal relationship or not? So quickly, you look at the strength of association. So if there is a strong association between a factor and an outcome, then this is more likely to be a causal relationship. This is more likely to explain the relationship. If there is consistency in the body of evidence, this also supports the notion that there is really, this hypothesis is sound and solid. You look at the specificity, like in the case of smoking and its association with lung cancer. So if smoking is there, lung cancer is there. If you do a case control study and there is no, the risk factor is not obvious in the lung cancer people, then you say there's a specificity between the cause and the outcome. Temporality is important. The incidence of the exposure before the outcome is important also. You look at the biological plausibility, which is animal studies and experimental study, the coherence of the evidences, and the experiment itself. So when you look at all these evidences, then you say, well, the hypothesis is sound, it's most likely plausible, we're going to accept it. So let's look at the hypothesis of systemic renal system, sympathetic nervous system denervation. This is animal data. In this part, you look at the level of norepinephrine in the control. Here is after ablation or de-innervation of the animal. And this is after surgical de-innervation. And it's very obvious that there is a completely decrease in the level of norepinephrine post-ablation or surgical de-innervation. This is in animal data. If you look at the human data, again, the same is true. This shows the level of norepinephrine in the serum in patients with early stage renal disease compared with end stage renal disease, 2 to 8 years and more than 8 years. And this is a healthy control. And this is hypertensive patients without renal failure. And what's quite obvious is patients with renal diseases and hypertension have high catecholamines and norepinephrine than normal control. Furthermore, there is a very important data from the surgical literature supporting that surgical sympathectomy results in good blood pressure control. And this is one of the most important studies that support this hypothesis. It's also, in this literature, they quote that patients who had sympathectomy had better symptom relief, they had lesser decrease in their cardiac size, less headache, and less complication. However, most of these early studies was associated with high morbidity and mortality. Nonetheless, this is one of the undisputable evidence that de-innervation of the kidney results in a better control of the blood pressure. More data comes from the end-stage renal disease. They get normalized their blood pressure after nephrectomy. Also from the transplant literature, we know that after transplantation, if you remove the kidneys after transplantation, blood pressure control becomes more easy and more controllable. Bilateral nephrectomy in kidney failure also leads to better control of the kidney. So if you look in the evidence in totality of the hypothesis, there is a gradient. The higher the level of the norepinephrine, the higher likely that there is hypertension. There is specificity, coherence, biological, et cetera, So it meets all the criteria that this hypothesis is solid, it's plausible, it's true. So the data unequivocally support that, that there is an important role for parasympathetic system in the control as well as the regulation of blood pressure. So the hypothesis is solid, no problem with that. So let's look at the translation. There is 2 studies that were published in the literature, Simplicity 1 and Simplicity 2. This is the population. The sample size is very small. They were resistant hypertensive in both cases. And in Simplicity 2, there's about 106. In Simplicity 1, 145 patients. And they measured the blood pressure after 6 months. Dramatic improvement in blood pressure control. 38% of the population had blood pressure less than 140 in 6 months. About 13% were deemed as a non-responder. In Simplicity 2, it was a randomized trial where they randomized patients to de-innervation versus placebo or control arm. And there was again a major reduction in the blood pressure, systolic about minus 30 millimeter of mercury after the procedure. So this is a very dramatic result. So this is depicted in chart format. So the decrease in blood pressure in systolic was 22 at 6 months, 27 at 1 year, and the decrement in blood pressure was really consistent and were stable and durable until a follow-up of 3 years. This is from Simplicity 1. Simplicity 2 showed the same thing, that there was a major reduction in systolic blood pressure, 32, and diastolic of 12, and this was noted at 6 months, and it was durable at 36 months as well. Simplicity 2 and Simplicity 1 told us, we learned from them that de-innervation can be achieved safely. There is a lot of safety data supporting the safety of the procedure. Mean blood pressure reduction across the trial was consistent between 30 to 20 millimeter of mercury. The reduction was durable. The blood pressure improvement sometime happened late or delayed. The treatment failure was in 10 to 15%. In other words, the success rate was about 90% to 85% success rate. This was followed by Simplicity 3, which is a larger randomized clinical trial. It was sham, so both arms of the trial had the procedure, the intervention arm as well as the non-intervention arm. The definition of the endpoint was the blood pressure for the intervention group minus the blood pressure in the sham group. So if there is a decrement in the blood pressure more than 10 millimeter, it was deemed to be a positive trial, and if not, this was deemed to be a negative trial. This is the result of the Simplicity 3. In this part of the chart, you see the de-innervation cohort, and this is the sham cohort. And the first thing you notice that the blood pressure dropped between baseline and post-intervention in both groups, and it was significantly different whether you were in the sham group or in the intervention group. There was significantly reduction in the blood pressure, most likely due to placebo effect. When you're in randomized trial, your blood pressure gets more controlled because you get more attention from doctors. If you compare the 2 bars with the 2 bars in the left side of the slide, there was no statistical significance between the 2 trial between the 2 group when it was done in a sham fashion. So This limitation of simplicity one, lack of control. It was just the intervention group that we looked at. The operator was not blinded to the study. Patient with accessory renal artery were excluded. Screening for secondary hypertension was limited, so there's a group of population with primary, secondary hypertension. Simplicity 2 was a better trial. It was randomized. However, the assessor of the endpoint were not blinded to the outcome and to the treatment allocation. SHA-M procedure was not carried out. Patient with more than mild hypertension, you would expect they would have higher adrenaline level, were excluded from the trial. Simplicity 2 and Simplicity 1 were negative, and was positive. Simplicity 3 was negative. So how would you explain that this trial is negative, yet there is 2 other trials positive? One of the explanation is a concept called the regression to the mean, and by that we mean in Simplicity 1 and 2, they took 1 measurement prior to the intervention, and that probably was very high. Had they repeated and took multiple measurements and get the mean, maybe it would have been a true estimate of the pre-procedure blood pressure. That was not done in Simplicity 1 and 2. However, in Simplicity 3, the patient required to have more than 1 measurement prior to the procedure, and they took the mean as a pre-procedure blood pressure, which is more accurate and reflective of the true blood pressure of the patient prior to the study. So that phenomenon happened in Simplicity 3. Elimination of placebo effect, patients were blinded, the physician was blinded, so there was no biases. The patient also did not know whether he had the study or not. They did a testing questionnaire as to evaluate how did the patient could guess whether he was blinded or not, and it was more than 0.5, which means that the patient could not guess which arm of the study he was assigned to. So in terms of the rigor of the study, it was really done in a very rigorous fashion, and it was really good trial, and I will leave the data completely. So let's talk about the technique and the technology that was deployed in these studies. So this is the Simplicity machine. This is the ablation catheter. This is the RF generator. You use an 8 sheet. You go to the renal artery and put some 4 to 6 lesions in a circumferential fashion, and each lesion lasts for 4 to 8 seconds. And the endpoint they used as to call it, we did a lesion or we performed the lesion. They look at the temperature rise, drop in the impedance, and this is the least to say from electrophysiological perspective is archaic and primitive, very primitive. The reason being is RF technology has a lot of limitation. We use RF in ablation of AV NRTs and accessory pathway. However, we use multiple inputs. Not only the RF, we use anatomical landmark, we use electrical landmark. We cannot rely only on just the impedance and the temperature. It's very difficult to assess the depth of the lesion, because if you look at only the temperature at the tip of the catheter, there's a heat dissipation, so the lesion has most of the time higher temperature than the tip of the catheter because of the cooling effect of the catheter because of the blood. It's also difficult if you want to make a circumferential lesion to use an RF and a 2D X-ray imaging, because when you make a circumferential lesion, you're moving from point to point, so most likely you're going to leave gaps. So how do you know that there's continuity of your lesion? And this is really challenging. Had you been an electrophysiologist, you would have known this is the basic concepts of making lesion. Force of sensing and ability. How do you know that you're in contact when you're using RF? How do you know that you're in contact with the organ? We use multiple ways to do that in electrophysiology. This was very, very difficult in the case of the renal artery. So the question that I ask when somebody tells me that I'm ablating the coronary artery, do you really have a circumferential lesion? How can you prove that? How can you validate that this is really circumferential lesion? Is there a gap? How do you know that there is a gap? Because when we do a lesion, and especially in circumferential lesions, we test for a gap. You have to test for a gap before you leave the lesion. Is there a validation process involved in lesion formation? Is there a good tissue contact? How do you know that you're in a really good contact? You could be in a contact you can tell that from the impedance, but that's not good enough. You have to know whether you're really good contact with the catheter or not. Superficial lesion versus deep lesion, we know that there's a lot of edema with superficial lesion, and with time, that edema heals, or if you cool the tissue, after warming up, that edema heals, and the lesion becomes very superficial and ineffective. So this is a diagram from pulmonary vein isolation, just to give you a flavor of how we do a circumferential lesion. So we move the catheter from one spot to another spot. In the past, before the era of the 3D mapping, this is really was associated with higher failure rate, because we're just blindly assuming that we really did a line and it's continuous. But the fact is that because we cannot have a validation, we left a lot of gaps, and these gaps can be a source of reentrant circuit, or in your case, it could be incomplete deinnervation of the pulmonary, of the renal artery, if you would. So using a 3D mapping technology, now you can be sure that you're in a good contact with the tissue. When you make a lesion, you can put a spot, a red spot there, and tag it. We call it, you tag a lesion there, and you don't leave a gap. So without this technology, you won't be able to know whether you did a good job or not. 3D mapping was very helpful. It verifies the contact. The catheter talks to us. So when we put the catheter in a certain position, it gives you a red color. It means I'm not in contact. If you push it against the wall, it becomes green. Then you know that there is a contact. And so you verify that you have a really good contact, so we can tell. There is quantification of the force. So contact is not enough. You have to have enough force applied to the tissue to form and create a lesion. So we have also a sensor that tells us how many grams of force we have against the tissue to form a lesion. Catheter position also with a magnetic field. You know where you're falling in 3D mapping versus when you're looking at an X-ray, which is quite difficult and challenging. Validation is important in ablation. When you make a lesion, how do you know that your lesion is effective? We validate that. We use other parameters. We use electricity. So this is before, and even you can tell that there's a difference between this debection and this debection, right? So there's lines here, and there's no lines here. So you know that we've done something. So tell me, when you did all this procedure, how do you know and validated that you've done a lesion? So without that, you cannot say we ablated the pulmonary, the renal artery.
2 minutes.
This is another way to overcome the lesion discontinuity or the gaps, is to use a balloon. We use that in certain ablation. Despite this, we always like to assume that this is really a complete occlusion and complete circumferential lesion, yet we still have some gaps because the ablation energy is not equal distributed in the lesion. So you might have certain area where you have a deep lesion and certain area where you have a more superficial lesion away from the jet. So this leads to a gap. So even this advanced technology, you cannot be sure with this that you have a complete lesion. This is a new catheter that's coming down the pipe for you to try in the renal artery. Hopefully you can improve your results and you can have more circumferential reliable lesions. So finally, a population could be an issue. So if you look at this example, this is a 60 years old male with hypertension, with normal renal norepinephrine. Would ablating this man really have an impact on his high blood pressure versus a 40 years old male with metabolic syndrome with the renal norepinephrine spills over that's really high? Ablating this gentleman maybe will be appropriate. So it's a matter of selection. We do believe that sympathetic nervous system play an important role in hypertension. However, it's not operating in all patients with hypertension. It may be in subgroup of patients, and it's a matter of identifying those patients who are at risk. So R&D does not cause a universal blood pressure reduction, incomplete denervation, and it's not operator in all patients. Finally, a few thoughts about studies. When looking at studies, this is one of the most downloaded paper in the literature of biomedical research. It's by Onidis. He's a professor at public health in Stanford, and it reads why most published research findings are false. Yes, that's what we heard. Why most published research findings are false. But the paper is misquoted and misunderstood. It doesn't mean that all research are false. It means the probability of having false research is higher than probability of having a true research. And that's nature of testing a hypothesis. You can hypothesize million hypotheses of explaining one thing, but a handful of them will be true. So most of our hypotheses are wrong to start with before even conducting the study. So it's a very interesting paper to read. I'm just going to share with you 3 corollaries that he quoted. He said the first one, the smaller the study conducted in a scientific field, the more likely that the research is false. So if you have a small sample size in a study, most likely, and you come up with a positive trial or a positive study, most likely, probability-wise speaking, is false result. Number 3, he said, the greater the flexibility in design, definition of outcome, analytical models and modes in the scientific field, the less likely the research finding is true. So even if you come up with a positive trial and you have a lot of flexibility in the population included, method of analysis, the design issues, most likely it is not true. And finally, if there is a financial conflict of interest, most of the drug companies' sponsored trials are positive. When it's replicated by independent bodies, it tends to be negative. And that's well established in the literature. It's undisputable. So he says the greater the financial and other interests and prejudices in the scientific field, the less likely the research finding is true. So in conclusion, Mr. Chairman, renal sympathetic nervous system is a cause of hypertension, and it's a very sound hypothesis. I believe that. There is a need for a better definition of population who would benefit from de-innervation therapy. Lack of clear and reliable endpoint due to technology and technical issues really most likely sits behind the failure in the field. And finally, this is artery. Dr. Stent, this is artery, coronary artery. This is renal artery. They're the same, right? There is a lesion, so you crush a lesion. Here is a lesion, you make a lesion. Geography is different. This is a land, right? But this is a runway, and this is grass. Although they're similar, it's so simple, but you're embarking on ablation, so you better understand well the lesion formation process. Thank you so much.